All right. Thank you so much for the introduction, Dirk, and thank you for giving me the opportunity to present this work at C-STAR. All right, so today I just want to say the work that I'm going to present today is coming out of my previous lab. So I want to thank all the co-authors and collaborators on the projects that I will be presenting today. Also, thanks to all the participants and the funding sources. And so in this talk, I will just introduce a few concepts that will just help us navigate this talk. And then I will spend the majority of time talking about neuroplasticity and behavioral changes following treatment in stroke aphasia. But I will also mention a study that we did in a participant with primary progressive aphasia. And then I'll present some pilot data using transcranial direct current stimulation in combination with treatment. All right, so as I'm sure I don't have to tell you, aphasia is an acquired language disorder that can occur following stroke, or it can be a symptom of a neurodegenerative disease. And in this case, we talk about primary progressive aphasia. And in both clinical populations, we can encounter what we define as agrammatism. In stroke participants, agrammatism is associated with Broca's aphasia mostly, and in PPA, we talk about agrammatism in the context of the agrammatic variant of PPA or PPA-G. So Broca's aphasia is characterized by difficulties in naming, mostly for verbs more than nouns. There are difficulties in repetition, and the speech is often slow, dysprosodic, with short sentences. There are phonological errors. And then the phenomena that are typical of agrammatism are the omission and substitution of morphemes, such as verb inflections, but also prepositions and articles. There are difficulties in sentence production. And then patients with agrammatism have also difficulties in understanding sentences in which comprehension must rely on syntactic cues. And this is the case of what we call non-canonical sentences. So canonical sentences are those in which the first participant encountered in the sentence is the one doing the action, so the agent. For example, active sentences such as the dog is following the cat, or subject clause sentences such as it was the boy who kissed the girl. And then non-canonical sentences are those in which this preference is not respected. And so the first participant is actually the theme or the person or character undergoing the action described by the verb. So primary progressive aphasia is a neurodegenerative disorder in which language deficits are the primary symptom, and other cognitive functions are, at least in the first 2 years of the disease, primarily intact. And the PPA-G or agrammatic variant has some similarities with with Broca's aphasia with agrammatism, and is distinct from the two other variants, the semantic variant and the logopenic variant, that I will not talk about today. So let's dive now in the first section of this talk, in which I will present neural and behavioral changes following treatment in stroke-induced agrammatism. So the efficacy of aphasia therapy has been debated until recently, due to the fact that many studies have small samples, or they're single case studies. There's also often a difficulty in disentangling the effects of spontaneous recovery from those of language treatment. And then different groups and different papers test or evaluate patients with different levels of aphasia severity, language profiles, and lesion extent, and all these factors can affect recovery. So it's often hard to compare results. And however, recent meta-analysis and randomized clinical trials have shown that impairment-based language intervention do result in improvement of language functions. So for example, recent meta-analysis by Gina Kike and co-workers has shown that semantic features analysis is an effective treatment for naming, and treatment of underlying forms is an effective form of intervention for sentence production and comprehension deficits. With respect to which areas of the brain are recruited during recovery, the debate is open. There are studies of spontaneous recovery that have shown that improved language functions are associated with reactivation of regions in the left hemisphere that are not affected by the stroke. And they also have shown that the location of the lesion may profoundly affect the trajectory of recovery. There's also evidence that activation of right hemisphere regions may be actually maladaptive. However, treatment-related studies that investigated treatment-related changes in activation have suggested that both spare tissue in the left hemisphere and homologous region in the right hemisphere may be recruited to support recovery of language functions. So in the first study that I will present, we try to investigate the effects of treatment for production and comprehension of passive sentences on behavior by using both offline measures, so accuracy, and online measures such as eye tracking. And we also aim to evaluate the effects of treatment on functional activation during an fMRI task. And we looked both within the language network and their homologue regions, but also within domain general regions. And then we wanted to assess the relationship between behavior and changes in functional activation. So in this study, we had 19 patients with agrammatic aphasia, and they were assigned either to a treatment group or to a natural history group. And after pre-testing, which included behavioral tasks, eye tracking tasks, and fMRI tasks, the individuals in the treatment group underwent 12 weeks of treatment of underlying forms. Whereas the individuals in the natural history group did not receive any treatment. And then following these 12 weeks, they repeated all the behavioral, eye tracking, and neuroimaging testing. So treatment of underlying forms is treatment that focuses on restoring comprehension and assignment of thematic roles, so understanding who is the agent, who is the theme in the action, and also focuses on the syntactic operations by which we convert canonical sentences into non-canonical sentences. So I will just illustrate briefly the comprehension part of the training. So the way it works is that we first present a comprehension probe. So it's a picture verification task. We ask the patient if the picture matches the woman was cleaned by the girl in the bathroom. And then we move on to the thematic role identifications. So we have cards next to the picture, and we ask the participant to point in the picture and among the cards to the agent and the theme and the action. And then the examiner shows the participant how to build an active sentence by moving the cards into the active template, and then asking the patient to identify again the thematic roles in the sentence. And then we show them how to derive the passive sentence from the active form. So we show them how the verb gets the past inflection, and then the by moves into template. And then we show how the theme moves to the beginning of the sentence in the passive sentence, whereas the agent is part of the by phrase. And then following this step, we go back to the comprehension probe. And the treatment in production is very similar, with the exception that the participants are actually building the sentences and producing the thematic roles. So in this study and in the following studies that we'll be presenting, the tasks that we use to measure the efficacy of treatment were the picture verification task for comprehension. So here is just simply deciding if the sentence that they hear and the picture that they see match or not. And we use this for both behavioral tasks and the fMRI task, with the difference that the fMRI task also included a control condition that was reverse speech combined with a scramble picture. And for production, we used this sentence production priming task in which there are two pictures that are exactly the same with the exception that the agent and the theme are reversed. And then the examiner produces a sentence that describes the picture on the left, and the patient is invited to produce a sentence just like it that depicts the picture on the right. And for the eye tracking task, we use a sentence to picture matching task. So the sentence was presented auditorily, and then the patient had to click on the picture that matched the sentence. Although here, what we were really interested in was to monitor the eye movements during comprehension. So the results of this study showed us that, so these are acquisition curves for all the participants in the treatment group in this study. For production and comprehension. And what we saw here was that, most patients, except two, showed a successful acquisition of passive sentences. Those were the ones that we trained. For comprehension, there was more variability, and there were clearly two different groups. A group of participants who showed successful acquisition in comprehension as well, and a group of participants that show no major changes. But group-wise, the natural history group did not show any changes. We also showed in this paper that TOF resulted in generalization in both production and comprehension. So the treatment group here in this graph, this graph shows that the treatment group showed significant increase in production of untrained passive sentences. So the same structures that we trained, but untrained items, but also generalized improvements to other structures, such as simpler passive sentences. So for example, those without the by phrase, or unaccusative sentences, such as the woman fell on the stairs, which according to some syntactic theories do share some structural properties with passive sentences. And in comprehension, we also saw generalization to untrained passive structures. And again, the natural history group did not show any changes. So one interesting finding was related to the eye tracking part of the study. And so before going into the results of the aphasic participants, I'm just going to show the results of a healthy group of individuals on this task. So here in this graph, you can see the time course of fixations to the target picture for active and passive sentences. And so whatever is above the horizontal line, it means that the individuals were looking at the correct picture. And whatever is below the horizontal line, it means they were looking at the wrong picture. So what we see here is that when healthy people hear the man was, they start looking at the picture where the man is the agent, is the one doing the action. That's the correct picture for active targets, but the incorrect one for passive ones. However, as soon as they hear the verb morphology lifted, then they correct their prediction and they start looking, when they hear a passive sentence, they start looking at the correct picture. And so by the end of the sentence, they show what we call thematic integration, which means that they are consistently looking at the correct target. Whereas this, in the red circle, you can see what we call agent-first strategy. And so in individuals with aphasia at baseline, that's these are the eye movements for passives only. And in black, you can see the line for baseline for all, so pre-treatment for all the patients together. And then at post-treatment in red, you can see the time course for people in the treatment group. And in blue, you can see that for the natural history group. So here what we see is that between pre and post-treatment, for both groups, actually, we saw a small shift in looks toward an agent-first strategy. but only the treatment group showed a significant above chance thematic integration. And if you look at the shape of their eye movements, is much more similar to that of healthy participants. So in this study, we also try to correlate changes in activation with the results that I just presented. So the accuracy results and the eye tracking results. And so what we saw on the fMRI task was that in the treatment group, but not in the natural history group, there were changes in activation, and specifically activation increases in the right hemisphere. And we performed an ROI analysis in which we selected regions from both hemispheres that belonged to the sentence processing network or to their homologues, and to the dorsal attention network to capture changes in domain general networks. And then we correlated those with changes in accuracy and changes on the eye tracking task. And what we saw was that the increased activation in the right hemisphere areas in both networks were positively associated with treatment gains, so with offline accuracy increases in comprehension of passive sentences, but also changes in the sentence processing network in the actually homologues of the sentence processing network were positively associated with shifts towards an agent-first strategy. And increased activation in the right region belonging to the dorsal attention network were associated with improved thematic integration. We thought that these results were pretty interesting. And so what we think we learned from this study is that treatment of underlying forms results in upregulation of right hemisphere homologues of language-specific networks and also domain general regions. And upregulation of right hemisphere regions is associated with improved performance on sentence comprehension measures for both offline and online measures. So one question that we had is how do we reconcile these findings with those that show a detrimental role of right hemisphere in recovery? And so what we noted was that most studies that report detrimental effects of right hemisphere recruitment during recovery haven't really looked at the effects of language domain specific interventions, but more at patterns of spontaneous recovery. So in a second analysis of the data that I have already presented, we looked at the same agrammatic participants, and we looked at activation on the same fMRI tasks at baseline, so pre-treatment and post-treatment separately. And we focused on the relationship between the activation and performance on language tasks. So here are the results, the activation patterns for the contrast between passive sentences and the control condition. For a group of healthy participants, that's the activation in yellow. And for the group of patients, here are all patients in the treatment and natural history group at baseline, so before they underwent treatment. And so here you can see that in the patients, there was a significant cluster of activation in the right inferior frontal gyrus that was pretty homologous, like mirrored the activation that we saw in the healthy. And then there was another cluster in the posterior middle temporal gyrus that was spatially adjacent to a small cluster found in the healthy participants. So looking at the relationship between this activation and measures of language processing, we found that activation in this right IFG cluster was negatively associated with comprehension of non-canonical sentences, whereas this activation in the posterior middle temporal gyrus in the right hemisphere was positively associated with the WAB AQ score, indicating that people with less severe aphasia had more activation in this cluster. Post-treatment, so these are the results for the treated patients only at post-treatment. What we saw was that this right inferior frontal gyrus cluster became bigger. And when we correlated with measures of language production, we saw that activation in this cluster predicted production of non-canonical sentences. So the relationship kind of reversed. And in this case, whoever was able to produce non-canonical sentences better also showed more activation in this cluster. And then we also found positive association between this cluster of activation in the right insula and IFG orbitalis and comprehension of non-canonical sentences. So this study suggests that in the absence of language domain-specific intervention, it seems that activation of right hemisphere regions that are not normally activated by healthy participants may actually be detrimental. Although this may differ between frontal and temporoparietal regions, as also suggested by other authors. However, language interventions may promote adaptive changes that render right hemisphere regions able to support recovery. So one question here that came up was which type of intervention? Is it specific to one type of intervention, the one that we are doing, or is it found across different language treatment? And so this is what we tested in this study that was recently published in Cortex, in which we examined changes in activation on a naturalistic auditory comprehension fMRI task, following language treatment that was provided either for naming, for spelling, or sentence production and comprehension deficits. And so we focus again on the relationship between activation changes and changes in behavior as well. So here we had 3 different treatment groups. The agrammatic group, those are the same participants that I've been talking about so far. But then we also had an anomic group and a dysgraphic group that were recruited and tested and trained at Boston and Johns Hopkins universities, respectively. And then we had a natural history group that received no treatment again. So for this study, we recruited patients that were at least high school educated. They had a single left hemisphere stroke in the chronic stage. We excluded patients that only had subcortical lesions, and we included people that were between 35 and 80 years old and with WAB-IQ between 45 and 95. So we excluded people that had very low WAB-IQ. So these 4 groups did not differ in aphasia severity or lesion size. So the way we measured treatment efficacy for the agrammatic group, we used the usual 2 tasks that I have already discussed. And to measure treatment for anomia, we had a picture naming task. And for the spelling treatment, we had a spelling task. And then all participants underwent this fMRI task in which they were asked to just listen to short stories or to a control condition, which was reverse speech. And then they were simply asked to press a button to indicate if it was real language or not, and then to listen and try to remember the stories, because we asked some questions at the end of the scanning session. So the behavioral results that speak in favor of treatment efficacy showed that all 3 forms of treatment were effective. So they resulted in improved accuracy on the measures that we use to capture these effects. Whereas the natural history group that received no treatment didn't show any changes in accuracy. So turning to the neuroimaging results, so here are the activation patterns for a group of healthy participants on the story comprehension task. As you can see, the story comprehension task activated the language network pretty reliably. And then also there was also some activation in the right temporal areas and partly in the IFG. And then we looked at activation for the same contrast, so real stories versus the control condition, in each of the 4 groups before and after treatment. So before treatment, none of the groups showed significant activation, actually. And following treatment, only the three treatment groups showed some activation, whereas the natural history group didn't show any suprathreshold voxels. So as you can see, all the three groups showed some activation in the anterior temporal lobe, but the group that received treatment for sentence production and comprehension showed also a few more areas of activation in the right hemisphere. So we, to assess the relationship between changes in activation and changes in performance, we did region of interest analysis. So starting with the regions that were active in healthy participants, we extracted the mean pulse signal from a series of ROIs that were either assigned to, they were either part of the language network or of their homologues, or they were part of domain general regions. And then we ran mixed effects regression analysis to evaluate differences in activation between pre and post treatment across all groups and also within each group. And then to evaluate also the relationship between changes in activation and behavior. And what we found was that the sentence treatment group showed significant changes in activation in the language network homologue. And these changes were positively associated with improved word and sentence comprehension, as shown in these two graphs. The spelling group also showed significant changes in activation in the language network homologues, as well as in domain general regions. However, these changes were not associated with changes in word or sentence comprehension improvements. And then the naming and the natural history groups did not show any significant changes in this analysis. So what we learned from this study was that treatment of underlying forms resulted in activation changes in language network homologues that were associated with improved word and sentence comprehension. And these are processes that are likely engaged during the fMRI task, which, as I said, was a story comprehension task. Spelling treatment also results in changes in language network homologues, but these changes may be due to improvement in processes that are other than lexical, sentence, or discourse level comprehension. One thought that we had was that maybe spelling treatment could have improved phonological discrimination and therefore improved the contrast between real stories and the control condition. And however, changes in neural activation following the naming treatment may not be captured by tasks that require processes that extend beyond a single word comprehension. So this tells us that perhaps the type of treatment, as well as the choice of task for the investigation of treatment-related neuroplasticity actually matters. Now I'm going to present a study in which we investigated neural activation changes and behavioral changes in an individual with PPA. So there is evidence that language treatment is effective in PPA. However, both studies trained naming, and not many studies investigated neural reorganization following language treatment. So here, what we wanted to do was to investigate the effects of treatment of underlying forms in an individual with PPA-G, whose initials were DK. And so here, we administered treatment in two different phases. In the first phase of treatment, we trained passive sentences, and in the second phase, we trained object class sentences. So here in these graphs, you can see the time course of accuracy in production and comprehension, respectively. For passive sentences, that's the bold black line, and for object class, that's the dashed line. So if we start with production on the left, you can see that before beginning treatment, DK was, his accuracy was hovering around 50 to 70% in production of passive sentences. And then throughout the first phase of treatment, when we trained passive sentences, he got up to 90%. he maintained the gains at 6 months and then started to decline and then remained around 60% until the end of the study. Production of object clefts was at 0 throughout the first phase of treatment because we didn't really expect any changes when we were training passive sentences on object cleft sentences because they are two different structures. And then, however, when we started training object cleft in the second phase, you can see that his accuracy progressively improved. For comprehension, his comprehension of passive sentences was pretty much high throughout the duration of the study, but comprehension of object clefts was around 25% for the first phase of treatment, and then when we started training object clefts, it progressively improved. So both treatment components, passive and object cleft sentences, induce some improvement, were somehow effective. And we also saw this when we looked at his eye movement during production of passive sentences using eye tracking. And so here the panel A shows the time course of fixations to the agent in a group of healthy people. So what this tells us is that healthy people, before producing the first participant in the sentence, they look basically at the agent first when they're trying to produce an active sentence, and then once they produce the agent, then they start looking at the theme and so forth. And then the opposite for passive sentences. So they start looking at the theme, and then before they actually produce the theme, they already start looking at the agent. And here in panel B and C, you can see the time course of eye movements for decay before and after treatment. So it's pretty clear how the shape of his eye movements was much closer to the healthy participants following treatment, but not very close before treatment. So indicating some changes in online production as well. And there were no changes in comprehension of passive sentences because his comprehension of passive sentences was quite good. So looking at the neuroimaging, these are the results, these are activation patterns for a group of healthy participants and decay before and after we provided treatment for passive sentences. And so you can see how after providing treatment, there is a significant increase in activation in the left frontal lobe. So in the IFG, but also extending superiorly to the middle frontal and superior frontal gyri, and also in the posterior temporal areas, and to some extent in the right hemisphere as well. However, these are the results before and after we provided treatment for object clefts. And here you can see how his activation was pretty similar before and after. So not much evidence for neuroplasticity in the second, following the second phase of treatment. This was an interesting case also because the patient had the agrammatic variant of PPA. However, he didn't really have much atrophy. These are atrophy maps at different times of the study, and you can see how atrophy was mostly either subcortical or actually anterior temporal, but along the midline mostly. So what we learned from this study was that TUF may promote neuroplasticity in PPA as well, and the neuroplasticity may decrease with the progression of the disease. And so based on these results, we also try to combine treatment with tDCS, with transcranial direct current stimulation, and stimulating the right hemisphere. So we did so in Agrammatism and in the same patients with PPA that I just presented. So for the results on Agrammatism, so this study examined the additive effects of high definition tDCS with combined with TUF compared to TAF alone or TAF plus sham. And we looked at both behavioral and neural changes. And so for TAF, we actually developed a computerized version of TAF that was delivered through iPad. And we used the same tasks, the picture verification task and the production task, to measure treatment efficacy. For the tDCS protocol, we used intensity of 2 milliampere. And then tDCS was delivered in conjunction with treatment for 20 minutes at the beginning of each session. And then behavioral treatment would continue for another 40 minutes. And we stimulated the right posterior middle temporal gyrus. So we plan to recruit 2 groups of participants. And so at baseline, we collected behavioral and fMRI measures. And then group 1 underwent 4 weeks, 4 times a week of real tDCS combined with TAF, whereas group 2 received sham. We collected behavioral and fMRI measures after this phase as well. We collected an extra behavioral measure 2 months after the end of the first phase of treatment. And then 4 months after the end of the first phase of treatment, we started phase 2. And in phase 2, we reversed the conditions so that group 1 underwent sham combined with TAF, and group 2 received real tDCS with TAF. And then we collected again behavioral and fMRI measures, as well as additional behavioral measures 2 months after the end of phase 2. So here we provide results only for 1 participant, and that's because we didn't really get the chance to complete this study because we didn't receive additional funding. And so we ended up recruiting 4 people with agrammatic aphasia. 2 in group 1, 2 were assigned to group 1 and 2 to group 2. However, 2 completed the study, whereas 2 dropped out. And of the 2 people who completed the study, 1 had unusable fMRI data. So here I'm just presenting the result for 1 participant. And so here what we saw, this participant was assigned to the sham plus TAF condition in phase 1, and then did real tDCS plus TAF in phase 2. And so here, obviously, what we see in phase 1 is that accuracy in production of both active and passive sentences significantly improved in the first phase of treatment, where, however, she didn't receive real tDCS. And then there was a decline over the 4 months of washout, and then there was another increase that, however, was much smaller during real tDCS combined with TAF. And for comprehension, the results were also not super exciting because the asterisks indicate difference from chance, and she actually improved and on active sentences only and after the first phase, but didn't really improve additionally after the second phase. However, the results on the fMRI task showed for the contrast between passive and active sentence, which is a real minimal pair, showed just after tDCS, but not after sham, some small increases in activation in the right hemisphere surrounding the site of stimulation, but also in other areas. And we also did a pilot study in PPA-G, and this one had, so this was the same participant decay that I presented earlier. So in this case, we had a slightly different design that had a tighter type of timeline. In this case, treatment was combined with real tDCS in the first phase for 3 weeks and provided 5 times a week. And we only had 1 month washout between the end of phase 1 and the beginning of phase 2, in which she received sham. And so here we did, because this patient had already done TOUGH, we did a different treatment. We treated production of verb inflections, present tense or past tense. This is the task that we use to measure the efficacy of treatment. So as you can see, there is a queue yesterday that alerts the patient to which tense must be used. And then the task is to describe the picture by inflecting the verb. And so in this case, we use a similar tDCS protocol, but with different intensity. We use 1 milliampere intensity, and we stimulated, the right inferior frontal gyrus in this case. And so here the results were a little bit more encouraging. So between pre-phase 1 and post-phase 1, where the patient received real tDCS, we saw significant increases in production of present and past verb inflections. And then, however, then his accuracy was pretty high at the beginning of phase 2, so he didn't further improve, but there was not much room for improvement. So obviously this was not an ideal design. However, the results of the obtained on the fMRI task, where he had to inflect verbs, but covertly. So this was not overt articulation, showed following the first phase, where he was administered a real tDCS. You can see how so we stimulated the right inferior frontal gyrus, but there was increased activation in the left inferior frontal gyrus and precentral. But between the changes between before and after the phase 2, where he received sham, were actually down regulation, so decreases in activation. So to conclude, what these studies can tell us is that impairment-based treatment for sentence processing, and specifically treatment of underlying forms, is effective for individuals with stroke agrammatism, as already shown by recent meta-analysis. And it seems that results are overall better for production and for comprehension. And preliminary results suggest that paper-based and computer-based versions of TOUGH may yield similar results, actually. We also found out that TOUGH promotes recruitment of right hemisphere regions because activation increases were positively associated with improved sentence processing. And these activation changes were found both in tasks that use similar paradigms and similar stimuli as the ones used in treatment, but also on naturalistic tasks, which suggests some possibility for generalization. And activation increases were seen both in regions that are homologous to the language network, as well as in domain general regions. However, it seems that the engagement of domain general regions may be depending on the tasks that we use to measure these activation changes. And the extent of right hemisphere recruitment may also be dependent on the function that is targeted during treatment. And finally, we have preliminary evidence that treatment of underlying forms may also be effective in treating sentence production deficits in individuals with agrammatic PPA. And here we found that activation changes in our PPA patients engaged both non-atrophied regions in the left hemisphere as well as right hemisphere regions. And finally, there is some suggestion that right hemisphere regions may be possibly used as targets for non-invasive brain stimulation. And with this, I want to thank you for your attention and open for questions.
Thanks for your presentation. That was really nice. I'm going to take a look in our room. Does anybody have questions from our? Yep, we do. We have a question from our room. Let me turn the camera as well.
Thank you so much for a really interesting talk. I wonder, with the studies where you see increased activation in the right hemisphere associated with treatment effects, what do you control for lesion volume, and lesion location, which generally is quite strongly associated with the activation patterns.
Yeah. So yes, I didn't say that, but in all the studies that I presented, lesion size was always introduced as a covariate. And I also tested, like in the most recent study that I published in Cortex, I just like looked at, if changes in activation in the right hemisphere were predicted by lesion size, and it wasn't. It's just, we didn't find that. As for lesion location, I didn't really exactly test this hypothesis. Also because in our sample, I want to say, well, at least for the agrammatic participants, we had pretty extensive lesions. So I would say, I don't know, I never really know how to test, like, should I divide, frontal versus temporal lesions? This was done by Dorothy Sauer, I think, in one of her papers. And I think most recently, Stephen Wilson published a paper where he carefully looked at like groups divided by lesions. So yeah, I didn't really do that. I had a small sample of agrammatic patients, but I could have done it maybe in for the study that I most recently published, because we had higher numbers, but then we also have the treatment variable. So dividing patients by lesion also did not seem too feasible with those numbers. But yeah, it's a great point. I mean, I'm sure that it has some effect. As for lesion size, I just didn't find it. I didn't find it in the fMRI task in the first study that was like passive synthesis versus control. And I didn't find it in a naturalistic story comprehension task.
All right. I don't think we have questions from the room here. We have questions online. So I'll read those out to you, Elena. We have a question from Kirana Tsapkini. Beautiful presentation and compelling data, Elena. Why do you think there's a change by the end of the sentence? This is about one of your earlier studies that you presented on eye track. Why do you think there's a change by the end of the sentence and not when they see the verb in passive form? Could it be the marker by? Also, the two networks, sentence and Dan, were they abnormally activated higher or lower before treatment? Is their post-treatment activation a normalization?
Okay, I can answer the second question first, I guess. In study 2, I presented the same data at baseline, so I could see that. Because in the first study I just looked at changes in activation, and this is a great point. So then in the second study, I looked at activation at the two different stages, so separately for pre-treatment and post-treatment. And I saw that pre-treatment, yeah, I mean, it was like abnormally activated, meaning that the healthy didn't really activate those regions in the right hemisphere. However, post-treatment, there was even more activation in the right hemisphere. So then I wouldn't call that like a normalization, I guess. And for the eye tracking results, so why there is a change by the end of the sentence? Yeah, well, what I'm guessing is that so the agent first strategy, which is the one that we do as soon as we hear the first participant in the sentence, is somehow an automated type of behavior. Whereas I think the thematic integration, so by the end of the sentence, is much more a controlled process. And I think that that's where we see the difference between the treated group and the natural history group, because I think they just put in place some strategies they have learned during treatment that are much more controlled, like top-down controlled.
Great, thank you very much. Another question from Kirana. It seems that the right hemisphere post-treatment activations were adaptive, right? Was this modulated by aphasia severity?
So yeah, we actually looked at aphasia severity. I think actually was a covariate in my analysis, and that was by itself. Sure, you would. Well, actually, I don't remember if it by itself was predictive, but I'm sure that the effects that I found took into account aphasia severity, and they were not due to that.
Okay, thank you very much. I had a question. Do you interpret the right hemisphere sentence processing homologue upregulation of activation that you find? And this is something I know you've alluded to it. You've talked about it a little bit. I was just wondering if you can say a little bit more about that. Do you interpret that right hemisphere activation as indicating that the sentence or discourse tasks are now performed in a different way? So, for example, using strategies or relying more on general cognition. Or do you think the right hemisphere is able to perform syntactic computations in the same way as the left hemisphere? And William piggybacked on that, and he had a nice quote from Baines and Gazzaniga, who 1988, who show in split brain patients that impaired syntactic comprehension.
Yeah, no, I don't believe that the right hemisphere has the same competence as the left hemisphere. Okay. I absolutely don't believe that. Okay. I am just, I'm actually, I think it's curious that we see consistently now across different tasks, we see this increases in activation, but I think they may related also to the type of treatment that we do. And somehow, maybe because we are treating sentences, I think that has some effects that we didn't really measure on working memory or, attention that could, help compensate for difficulties in performing syntactic processing. But I don't, and that was also suggested by the correlation between changes in domain general network, in the dorsal attention network, and this improved thematic integration at the end of the sentence. So with the idea that those are like top-down controlled processes that they somehow learn to do because they undergo treatment, and the fact that these are positively correlated with engagement of the domain general network, I think, it may be the first hypothesis that you put out is the one that I'm thinking,
But that, it does imply then, right, that you can do those syntactic tasks with pretty impaired syntax, right? Or it implies that what is actually broken in these patients is not the syntax, but that domain general stuff you're talking about. It's either or, right?
Well,
or am I not wrong, right about that?
I mean, so I do think that our patients also show, especially in stroke, I would say, they do show some difficulties with executive functions. Some show impaired working memory as well. So that doesn't, I think they're, those are difficult to disentangle when talking about sentences. However, I think, because of the difficulties in other aspects of grammar, such as, verb inflections, I don't think that agrammatism is explained simply by difficulties in domain general functions. I think there is evidence that for sure that there is an impairment in morphosyntax. However, it may be that there is also a mild impairment in domain general functions that normally in healthy people probably support sentence comprehension and sentence production, and that through treatment we may address both the syntactic component but also these domain general functions, and therefore that's what we see in the right hemisphere.
Thank you. William adds to that. So is the claim that left hemisphere language areas equal linguistic processing and left hemisphere domain general areas equal domain general whereas right hemisphere language area homologues equal domain general?
I mean, I don't, that's that's tough. I don't see it necessarily like this. I think that there's, for example, semantic, I mean, there's enough evidence that there are semantic capabilities in the right hemisphere. I think, you know, it's hard with the data that I have to disentangle the effect of domain general functions or like slightly improved semantic processing, maybe at the in the semantic construction, like semantic combinatorial type of processes. So yeah, perhaps there's, you know, I don't think so. The evidence of that comes from healthy people doesn't really indicate that the right hemisphere has specific syntactic competencies. I think that this is what we see, right? However, I think that it's possible to improve on the tasks that I presented through a mix of improved semantic processing in a combination with improved domain general functions. That's where I am for now.
Thank you. Yeah, I think that makes a lot of sense. So William also adds, your explanation of how agrammatism is recovering seems very reasonable to me being William, but
Yeah.
he's still trying to wrap his head, like all of us, around the right hemisphere activation patterns, right? Kirana Tsapkini had another comment. Lesion size or aphasia severity would be best as a fixed factor in the regression, not a covariate, because then you remove the variance, but you need to use it as an interaction term to test it. Can you comment on that?
Yeah, I think this is a good suggestion. I will do that.
Nice and easy. All right. I think that brings us to the end of the questions. If there's nothing here from the group. No. Okay. So thank you very much, Elena.
All right. Thank you.
Nice. Thanks, audience, for your questions and participation. And we hope you will join us again in 2 weeks when we'll be listening to Lindsay Cater. Bye-bye.
Bye.